Okay, so macrocytic anemias. First of all, how do you identify that there is a macrocytic anemia in the question or in real life if anybody's blood report has a macrocytic anemia? You simply look at the MCV, which is above 100. MCV below to 80 is macrocytic anemia, and above 100 is macrocytic anemia. First one being megaloblastic anemia. It is the reason why it happens is because there is impaired DNA synthesis, and I'd like to highlight that. There's impaired DNA synthesis, and there's maturation of the nucleus of precursor cells in the bone marrow, delayed relative to the maturation of cytoplasm, which means that the cytoplasm is not mature. One thing that you need to understand, guys, is that the more the cell gets mature, the more its size shrinks. So if this is a cell, if it undergoes maturation, the size is going to shrink. Okay, that's what's going to happen. So maturation results in the cell being small. So that's what is a constant theme involving the hematopoietic cells or cells that are involved in hematology. So this is a common thing. So the more the mature the cell is, the smaller its size will become. So what they're saying is that the maturation of the nucleus is delayed relative to the maturation of the cytoplasm. So that is why in megaloblastic anemia, you find that there are hypersegmented neutrophils. Of course, RBCs don't even have a nucleus. So the cytoplasm is big, but if there is a nucleus present in any cell, it is going to be of a bigger size and it is going to be a bit of an immature in its structure. So that's what they're saying. So there is delayed maturation of the nucleus. You need to keep that in mind. It is a nucleus problem. Okay. And the causes of it are vitamin B12 deficiency, folate deficiency, and medications quite important, which are hydroxyurea, phenytoin, methotrexate, sulfur drugs. So you need to keep all of this in mind. Hydroxyurea, phenytoin, methotrexate, and sulfur drugs. These are very important. Also, these are two main causes: vitamin B12 deficiency and folate deficiency. You have to keep in mind the findings, which are glossitis, and can cause RBC macrocytosis and hypersegmented neutrophils. So now we're going to discuss the two causes of it. So folate deficiency causes the most common cause is chronic alcohol overuse. That's the most common cause. And then there are also other causes such as malabsorption, drugs, methotrexate, trimethoprim phenytoin, and folate deficiency could also occur in hemolytic anemia or pregnancy. These causes you have to keep in mind, right? Drugs are specifically important that cause folate deficiency, which are trimethoprim, methotrexate, phenytoin. These are quite important, all three of them. Also, this could occur in sickle cell disease. Folate deficiency could also occur in sickle cell disease. Reason being is because the cells are being hemolyzed. So we read here that hemolytic anemia causes increased requirement of the folic acid. So sickle cell disease causes hemolysis, and due to that hemolysis, folate is consumed rapidly. That is why it can also occur in sickle cell disease. And pregnancy is very important as well. So you need to keep in mind pregnancy is a important factor. And these drugs are also important. Okay. So what happens is that there is increased homocysteine. This is what is found in the lab. So the homocysteine is increased, but methylmalonic acid is normal, and there are no neurological symptoms. In B12 deficiency, there are neurological symptoms, and in B12 deficiency, methylmalonic acid is also increased, as you can see over here, along with homocysteine. Now, why both of them are increased? Because there is a biochemical pathway which folate is the cofactor, and if there is no folate, then homocysteine is usually converted into something else, using folate. But if there is no folate, then homocysteine cannot be converted and it rises. So for that, you need to check out the biochemistry section. So it is normally converted into something else using folic acid. But if this is down, so this conversion will not occur, or this is going to rise. Similarly, looking at the vitamin B12, which is also known as cobalamin deficiency, it, the causes are, the most common cause in this case is pernicious anemia. Pernicious anemia basically, it it is basically anemia against the parietal cells. Anemia, excuse me, it is basically the autoimmune reaction against the parietal cells. Now, the parietal cells release intrinsic factor, they also release acid, which are important for the absorption of vitamin B12. And if there is pernicious anemia, there is not going to be B12 absorption. So that is why it is the most common cause of B12 deficiency. And malabsorption can also be a cause. Crohn's disease is important. You need to remember this. Pancreatic insufficiency, gastrectomy, very important again. And or if the patient is, read up this, the patient is vegan because B12 is taken from animal sources. So if the patient is vegan, then it can also be a problem. And Aphilobothrinium latum is a fish tapeworm which consumes vitamin B12. So this is also a reason for its deficiency. Malabsorption can occur in all of these, right? So in Crohn's disease, in pancreatic insufficiency, gastrectomy, however, is the same thing as pernicious anemia. You're just taking out all the parietal cells. So it is the same thing as pernicious anemia. Right? And or you can have insufficient intake of it. Again, there's going to be high methylmalonic acid, which differentiates it, and neurological symptoms are also going to be present. So the first neurological symptom will be dementia, but it is going to be reversible. So whenever the patient has dementia, you have to check for a few things. You have to check for vitamin B12, you have to check for thyroid, you have to check for depression. So these 3 or 4 things you have to check, because if these are not ruled out, then what can happen is that these can be the causes of the dementia that the patient is suffering from, and these are very easy to reverse. Like you can reverse depression, you can reverse thyroid problems, you can reverse vitamin B12 deficiency. So these are easier to treat. That is why we first rule out these causes so that we can move to something that is more complex. And the most important part is subacute combined degeneration occurs. Uh, what basically this is basically a defect in the spinocerebellar tract, the lateral corticospinal tract, and the dorsal column dysfunction. So these 3 tracts are affected: the spinocerebellar tract, the lateral corticospinal tract, and dorsal column dysfunction. So vibration and soft touch is going to be disturbed, and pain, uh, motor abnormalities are also going to be present, and there's going to be ataxia due to spinocerebellar tract. The reason why these are affected is because B12 is involved in fatty acid synthesis. So fatty acids are used in myelin synthesis, and B12 is involved in fatty acid synthesis. So if fatty acids will be defective or will be deficient, then myelin is essentially going to be deficient. And if myelin is deficient, then all of these tracts are going to be affected. That is why B12 primarily gives neurological symptoms. Yeah. So folate supplementation in vitamin B12 deficiency can correct anemia but worsens neurological symptoms. So that is why you always give B12 with folate. You do not give them alone or in a single formulation. You have to give both of them together so that you could avoid the worsening of neurological symptoms. Of course, you have to rule out which what the specific reason is, which deficiency is present, but you have to keep in mind that neurological symptoms can worsen. So you have to give folate and B12 together, not just one in any one of them. Okay, so historically, it was diagnosed by the Schilling test, a test that determines if the cause is dietary insufficiency versus malabsorption. So, Schilling test is not really used these days, but you can keep in mind what that is. So, the primary function of the Schilling test is to differentiate the cause is dietary insufficiency or malabsorption. That is the rationale of the Schilling test. Anemia is secondary to insufficient intake may take several years to develop due to liver's ability to store B12 versus the folate deficiency, which takes weeks to months. So this is basically a point to keep in mind if the presentation involves a long-term defect or a short-term defect. So if the question is giving you a history of long-term dietary insufficiency, then you can go towards B12. But if it is a short-term history, then folate would be more likely if other clues are not given. So you can use this point. But B12 has a lot of stores in the liver, so B12 deficiency takes quite a few years to develop. Whereas folate stores are not that much. So you can see its signs very early on. Moving on to orotic aciduria, it is also a megaloblastic anemia. Orotic aciduria happens when there is an inability to convert orotic acid to UMP in the de novo pyrimidine synthesis pathway. So, in this pathway, if I could show you guys pathway, this is the this is the part. Okay, this one. So orotate gets converted into UMP using UMP synthase. So it happens when orotic acid is not able to be converted into UMP, and it is a defect of UMP synthase because that is the enzyme that is involved in the conversion. It is an autosomal recessive disorder, presents in children as failure to thrive, developmental delay, and megaloblastic anemia, refractory to folate and B12. And there is no hyperammonemia present. There is no hyperammonemia present, unlike ornithine transcarbamylase deficiency, which also increases orotic acid with hyperammonemia. So, what basically these are saying is, let's talk about the first part. Is that I've showed you that this step cannot occur. So, what happens is that, of course, if orotate is not orotic acid and orotate are the same thing. So, if orotate is not able to be converted into UMP, then orotic acid is going to rise in the blood, right? And what happens is that when that happens, there are some things that occur. So there is failure to thrive, there is developmental delay, and megaloblastic anemia occurs. So these are the three things that happen. So there is failure to thrive, there is developmental delay, and megaloblastic anemia. But what they're explaining in the second part is also a biochemistry aspect. Is that orotic acid rises in two disorders. So there are two disorders. So one is orotic aciduria, and the other is ornithine transcarbamylase deficiency. What happens is, if I could show you that pathway as well, it's in the urea cycle. Okay, so wait a minute. Yes, yes. So this is the pathway of ornithine transcarbamylase, and you can see that this OTC is the enzyme that we're talking about. So if this is deficient, then ornithine is going to rise. But same as in the hair, this also happens. There was another good uh, picture in which there was a bit of more detail. So yeah, so basically, what we're saying is that ornithine transcarbamylase, if it is deficient, then what happens is that it can also lead to the accumulation of orotic acid. I want to show you the orotic acid and ornithine pathway. So orotic acid, ornithine pathway. Okay, I believe this is the one. Okay, so I finally found a picture which shows the connection between both of them. So it's a bit technical concept. So what happens is that if there is ornithine transcarbamylase deficiency and this OTC enzyme is cut off, which means that it is not present, carbamyl phosphate rises. And then what happens is that carbamyl phosphate, when it gets accumulated in the mitochondria or in the cytosol, it blocks the uh, conversion of orotic acid to uracil. So what happens is that both of them, both disorders, so there are two disorders, right? And both of them increase the level of orotate. This is a basically biochemistry topic, but we're just discussing it so that you get the context. So both of these disorders increase orotic acid levels in the body, but one of them increases ammonia levels. So of course, if the urea cycle is not working, it is going to increase the ammonia levels. So OTC deficiency is going to increase the ammonia levels. But if there is a deficiency of uh, UMP synthase, then this is not going to increase ammonia. So this disorder is not going to increase ammonia, right? The reason being is that this is not related to ammonia. Okay, so there is no hyperammonemia in this. So this is important. This difference is important to remember, and I hope you remember this when you're studying your biochemistry as well. This is how you are supposed to study and link both of them. Of course, if orotic acid is increased in the blood, then you're going to find it in the urine. It is increased in the blood. You're going to find it in the urine. The treatment is you either give the patient the uridine monophosphate or uridine triacetate. So what happens is that these precursors do not need any UMP synthase enzyme. They're just going to bypass the mutated enzyme. Okay, so non-megaloblastic anemia now. So both of these are macrocytic anemias. Megaloblastic is just named differently because it has impairment of DNA synthesis, whereas non-megaloblastic anemia is a macrocytic anemia in which the DNA synthesis is normal. And the most common cause, again, here is chronic alcohol overuse and liver disease. And this is very important. Most students don't tend to remember this anemia. It's very important. RBCs are macrocytic, but there is no hypersegmented neutrophils. Reason being that there is no defect in the DNA. So the DNA is mature and it's normal, unlike in this case. DNA was not mature. Okay, so that's the point. Chronic alcohol overuse can cause macrocytosis, and liver disease can also cause macrocytosis. Diamond blackfan anemia, it's a congenital form of pure red cell aplasia, which means there are no red cells. And it is a rapid onset anemia within first year of life due to intrinsic defect in erythroid progenitor cells. So the cells that actually make RBCs are defective. So what happens is there are no RBCs, right? And if some of them are there, they are macrocytic. And there's a contrast between this and Fanconi anemia. which causes pancytopenia. So Fanconi anemia affects all of the cells, and diamond black cell anemia only occurs RBCs. So keep that difference in mind. The lab in labs, you can find increased percentage of hemoglobin F, but total hemoglobin is going to be decreased. So you have to keep in mind that this could be given in the paper. Of course, you have to remember the physical defects as well that are present in the patient. So short stature, craniofacial abnormalities, and upper extremity malformations, most of which is the tripharyngeal thumb. And if I could show you, so craniofacial abnormalities are going to be present. Uh, I could, tripharyngeal thumb. So it's going to be, let me take a picture of it. This is what tripharyngeal thumb looks like. You can see it is a very long thumb. Usually your thumb has only two phalanx. So this picture can be given in the paper. So this is important. You must remember that this is related to diamond black cell anemia. Okay. And these are our macrocytic anemias. Normocytic, normochromic anemias now. So normocytic, normochromic anemias are classified as non-hemolytic or hemolytic because everything is normal. So we need something else to classify them. Their size is normal, their color is normal. So still, if what happens if the person has normal sized RBCs and normal colored RBCs and still has less RBCs? So now we need something to classify the difference on, right? And the difference is going to be classified on the fact that whether there is hemolysis or there is no hemolysis. Because if the size is normal and the color is normal, then every other reason is basically ruled out. So the only reason there could be is because if there is something that is destroying the normal RBCs, whether by hemolysis or not by hemolysis, by any other mechanism. So hemolytic anemias are further classified according to the cause of the hemolysis. So either it is the intrinsic cause or the extrinsic cause, and intrinsic or extrinsic to the RBCs also. So when we say that there is an intrinsic cause, we say that the problem is intrinsic to the RBCs. Or if we say that that it is an extrinsic cause, it means that the problem is extrinsic to the RBCs. And also by the location. And if you're talking about location, then we use the word intravascular or extravascular. So that basically means that if it is uh, where the hemolysis is occurring, basically inside the vessels or outside the vessels. So that's the point. Okay. So hemolysis can lead to an increase in the LDH. This is an important point. Can lead to an increase in the LDH, reticulocytes, unconjugated bilirubin, pigment gallstones, and neurobilinogen in the urine. So this is something that you must keep in mind. This is something that you must keep in mind is that there's going to be an increase in the LDH, the reticulocytes, unconjugated bilirubin, pigment gallstones, and urobilinogen in the urine. And what basically is extravascular hemolysis is, I remember this by intravascular is inside the vessel. So RBCs are getting destroyed inside the vessel, and or RBCs are getting destroyed outside the vessel. Outside the vessel, which means that they're getting destroyed in the endoreticuloendothelial organs, such as the spleen, the liver. So they're getting destroyed in the spleen or the liver, or they're getting destroyed inside the vessel by any circulating antibody or autoimmunity or any other effect. That is the difference. The main part, the main difference which is present, is explained in these paragraphs. Is that an intravascular hemolysis, there's going to be a decrease in the haptoglobin protein. Now, you know what the haptoglobin protein is that if we could label the haptoglobin protein by Hg, what it does, it basically joins with any free hemoglobin present in the blood. So if this is an RBC and this is getting hemolyzed, what happens is this is going to release hemoglobin in the blood, right? And hemoglobin is toxic to the kidneys. So hemoglobin cannot just it cannot be let to flow freely in the blood. So it has to be bound by a protein so that it does not affect the kidneys because it is toxic for the kidneys. So what haptoglobin does is that it combines with the hemoglobin. So more hemoglobin that is released in the blood, and more haptoglobin that is combined with the hemoglobin is going to result in the decrease in hemoglobin in the haptoglobin levels. That's what it's going to do. So thus there is decrease in the haptoglobin levels. So if there's decrease in the haptoglobin levels in the question, you understand that they're talking about an intravascular hemolysis. Of course, because if this is the vessel and hemoglobin is released into this vessel due to the hemolysis of RBCs, then haptoglobin has to combine with it. Then haptoglobin has to combine with it, right? In order to decrease the toxicity that hemoglobin can cause. So that's what's going to happen. And they're going to be increased schistocytes on the blood smear. Is the reason why we get schistocytes is because if I could clear this all out. So this is the vessel, and if there is any defect in the vessel, let's say there are platelets that are aggregated, or there's any defect. Basically, this is the RBC. At any defect for whatever reason, even if they are not platelets, any reason, if they are willing to destroy the RBCs, that sometimes what happens is that they are not able to destroy the complete RBCs. So they are not able to destroy the complete RBCs, they are able to just destroy a part of it. That is going to result in schistocytes because it is intravascularly happening. That is why schistocytes are going to be visible on the blood smear. And there's also going to be hemoglobinuria, of course. If there's going to be a large amount of hemoglobin released into the blood, some of it is going to eventually reach the kidney and cause hemoglobinuria, which is toxic to the kidney. And hemosideриnuria as well, because of course, if the iron gets deposited in the blood, if the hemoglobin gets deposited in the vessel, then it can combine to form hemosiderin as well. So, of course, it can lead to hemosideриnuria as well. Okay. And urobilinogen in the urine is also going to occur. Reason being that some of the hemoglobin is going to be converted into urobilinogen as well, and it's going to be visible in the urine. Notable causes are mechanical hemolysis, which is prostatic valve, paroxysmal nocturnal hemoglobinuria, macroangiopathic hemolytic anemia. These are the causes of intravascular hemolysis that you must keep in mind. These are the causes of the intravascular hemolysis. Extravascular hemolysis, the mechanism is that the RBCs are cleared in the spleen. So they are outside the vessel. So because this is outside the vessel, schistocytes are not going to be visible. And we don't need haptoglobin to come and save the day now because hemoglobin is released inside the organ. So it's not really a harmful thing now. So macrophages in the spleen clear the RBCs. And the findings include splenomegaly, spherocytes in peripheral smear. Let me highlight this. So splenomegaly is going to happen because spleen is working overtime to clear the RBCs. Spherocytes are going to be visible in the peripheral smear, most commonly due to hereditary spherocytosis, which is a extravascular hemolysis. and autoimmune hemolytic anemia as well. Most people seem to forget autoimmune hemolytic anemia, but you have to keep in mind that this autoimmune hemolytic anemia also has spherocytes. It also has spherocytes. For whatever reason, it's not really clear, but it also has spherocytes along with hereditary spherocytosis. So both of them have spherocytes. Keep that in mind. And both of them are a part of extravascular hemolysis. There is going to be no hemoglobinuria, hemosideриnuria. I've already told you guys, and can present with urobilinogen in the urine. Urobilinogen in the urine is basically when uh, excess bilirubin is deposited into the liver. So it can happen in both intravascular and extravascular hemolysis. So keep that in mind. All right. So these were the hemolytic causes of the hemolytic anemia. Now we're going to look at the causes of non-hemolytic and homocytic anemias. So if hemolysis is not occurring, what is the reason? Anemia of chronic disease. Uh, the yes reason, the starting reason, is that there is inflammation because it is due to the chronic disease, presence of the chronic disease. So there is inflammation. What inflammation does is that inflammation increases the IL-6, uh, interleukin 6. What this does in turn is it increases hepcidin. Hepcidin is a protein that is released by liver and it binds ferroportin on the intestinal mucosal cells and macrophages, thus inhibiting iron transport. Right. So let me show you guys. So hepcidin and ferroportin dynamic, and hopefully there is an image illustrating that. Okay, and this does not seem to load. Right. So you can see that hepcidin is released by liver. So IL-6 is acting on the liver, and just forget about what this is happening. IL-6 is acting on the liver, and it is releasing hepcidin, and hepcidin in turn goes to the mucosal cells where ferroportin is there. Ferroportin is this channel, and ferroportin is blocked. Hepcidin is releasing and blocking ferroportin. And ferroportin is present on three cells: hepatocytes, duodenal enterocytes, and macrophages. So it is present on three cells. To keep that in mind, it's present on three cells. So if you're annotating your FA while watching this video, then you just keep this in mind that it's present on three cells: hepatocytes, duodenal enterocytes, and macrophages. And what it does is it just blocks the transfer of iron. So it acts like a gate and blocks the transfer of iron from the inside to the outside, from the liver, from the macrophages, and from the enterocytes. What happens is that there is a decreased release of iron from macrophages and there is decreased iron absorption from the gut naturally. So the associated conditions which give rise to this kind of anemia, if there is less iron releasing, so iron levels are going to go down, obviously, and the DIBC is also going to go down. The fat is going to increase. Why these two happen? I'm going to explain just in a bit. So the associated conditions with such a chronic infection are with this anemia are chronic infections, neoplastic disorders, chronic kidney disease, very important, and autoimmune diseases such as SLE, rheumatoid arthritis. So you got to keep in mind the causes because there is nothing too much happening in the etiology. It's quite simple. Now iron is obviously going to decrease because it's not being absorbed or released. TIBC is going to decrease as well because there is no iron to be carried around. But ferritin is going to increase because iron is essentially getting in the body. It is getting stored, but it is not getting in the active form in the body. So you can say that the stored form is increasing. So you keep in mind that the ferritin is going to increase. right? This is different from iron deficiency anemia. This is not iron deficiency anemia. The ferritin is going to increase. This is normocytic, but can become microcytic. It can also present as microcytic. So this is going to help you differentiate the ferritin level. They would present this in the question as well. Treatment is to address the underlying cause of inflammation, judicious use of blood transfusion, and you can also consider EPO in chronic kidney disease. I think one thing that is quite important here is that you can consider erythropoietin use in chronic kidney disease for anemia of chronic disease. So this is the point that you can treat it by addressing the cause of inflammation or the use of blood transfusion or using erythropoietin. Aplastic anemia is the failure or destruction of hematopoietic stem cells. So the cells that are producing hematologic cells, they are getting destroyed. And the causes, again, are very important. So this is the mnemonic that they've given, reducing volume from inside diaphysis. It's just basically radiation, most important cause. Viral agents such as EBV, HIV, hepatitis viruses, Fanconi anemia, which we've studied previously in comparison of black diamond black fun anemia. It is autosomal recessive DNA repair defect, which causes bone marrow failure. So, associated findings are short stature, which is also present in the diamond black fun anemia, but cafe au lait spots is new, and thumb radial defects are also new. It can also lead to the to being the to lead to the patient being vulnerable to many malignancies as well, and it can be idiopathic. Uh, Stem cell defect could be there, may follow acute hepatitis. So keep this in mind that it may follow acute hepatitis and or the drugs. Drugs are very important. So benzene, chloramphenicol, alkylating agents, and antimetabolites. Very important. So you have to keep all of these causes in mind for a plastic anemia. All of these are important. Radiation, EBV, HIV, hepatitis viruses, Fanconi anemia, capillary spots, thumb radial defects, acute hepatitis, idiopathic cause, benzene, chloramphenicol, chelating agents, and metabolites. Reticulocyte decreases because, of course, this is a bone marrow defect. So reticulocyte count is going to decrease. EPO is going to increase because RBC production provides negative feedback to EPO. So if there are going to be less RBCs produced, EPO is going to increase due to the lack of negative feedback. Pancytopenia is characterized by anemia, leukopenia, and thrombocytopenia versus aplastic crisis. Aplastic crisis only has uh, anemia. We studied this in beta thalassemia as well, in which uh, parvovirus can cause aplastic crisis. So aplastic crisis involves anemia only, whereas aplastic anemia involves pancytopenia. Normal cell morphology, but hypocellular bone marrow with fatty infiltration. They normally do ask this description or they describe it in the question. Symptoms could involve fatigue, malaise, pallor, purpura, because of bleeding. Basically, symptoms of all of these. Treatment is going to be withdrawal of the offending agent. Immunosuppressive regimens such as anti-thymocyte globulin or cyclosporin can work to reduce any autoimmunity, such as where was the autoimmune disease? Yeah, so they can reduce autoimmunity, and you could also carry out a bone marrow allograft. See, RBC platelet transfusion can also be done, or bone marrow stimulation can be done due to uh, granulocyte, macrocyte, colony stimulating factor. So this could happen. Granulocyte, monocyte, colony stimulating factor. So this can also be used. These are the treatment for aplastic anemias. And hope this one is clear. Okay, so intrinsic hemolytic anemias. So we were discussing normocytic anemias, and we've discussed the non-hemolytic ones. Now we're going to discuss the intrinsic ones, the intrinsic hemolytic anemias. Right. So first of all is the hereditary spherocytosis. It is primarily autosomal dominant. So you must remember that it's due to a defect in proteins interacting with RBC membrane skeleton and plasma membrane. Right? Which one of these proteins are important to remember? These ones, the anchorin band 3, protein 4.2, and spectrin. You have to keep these in mind. Small round RBCs with no central pallor. This is the description. So if I show you spherocytes versus normal RBC. So this is what basically a spherocyte looks like. It has no central pallor. Uh, in contrast to the normal RBC, it has a central pallor. The spherocyte has no central pallor. It is just basically going to appear as a blue cell, a red cell, complete red cell. So I have a picture of a smear as well. This is a normal RBC, and this is spherocyte. You can see that there is no brightness in the middle. There is no pallor. Okay. So it has no pallor, and the reason why that is so is because it has a decreased surface area to volume ratio and dehydration. Yeah, so that's the same thing. It has decreased surface area and dehydration, and increased MCHC is going to be there. So keep this in mind. This is an important lab finding. I think this is the only condition in which MCHC is going to increase. So keep this in mind. This is important. And due to this distortion, there's going to be a premature removal by the spleen, and it's going to result in the extravascular hemolysis of the RBC. This is in turn going to lead to splenomegaly because spleen is again working overtime to remove the RBC, and it can also lead to pigmented gallstones. As I've told you guys, that hemolytic anemias can give rise to pigmented gallstones. This is important because the patient can get gallstones, and if they are pigmented, then it means that they are from spherocytosis. And aplastic crisis can occur in this, same as beta thalassemia, due to the parvovirus B19 infection. Okay, so although this is uh, you might say that this is an extravascular hemolysis occurs due to extravascular hemolysis. This is an intrinsic defect. So the problem is in the RBCs. You can see that the problem is in the RBC membrane. So you have to keep that in mind. The labs there's going to be an EMA test, which we do, and what that is going to show, it's just going to show us that there is decreased mean fluorescence of RBCs in it. Right, so there is decreased mean fluorescence of RBCs. You don't need to know what this is, but you just need to memorize it, that there is going to be decreased mean fluorescence in the EMA test, and there's going to be increased fragility in the uh, salt hypotonic test. So there are two tests to check this. One is the EMA test, which shows decreased fluorescence, and then there is the uh, hypotonic solution fragility test, you might call it, which shows that the RBCs are more fragile in the osmotic fragility test. Yeah, this is the name right over here. So there are two tests. Okay, so these two are the tests, and the MCV could be normal, as it is a normocytic anemia. It can sometimes be decreased, but this is not an important point, so you don't need to keep this in mind. The treatment is splenectomy. This is the treatment of pseudocytosis. Paroxysmal nocturnal hemoglobinuria. So it is a hematopoietic stem cell mutation which leads to increased complement-mediated intravascular hemolysis. So complement binds to the cells rapidly and results in the hemolysis, especially at night. And this occurs due to the acquired PIGA mutation and impaired GPI anchor synthesis for decay accelerating factor or CD55 and membrane inhibitor of reactive lysis and CD59. So what basically all of this means is that there is a mutation, PIGA mutation, in the anchor synthesis for DAF, CD55, and MIRL, membrane inhibitor reactive lysis, or CD59. So what these basically do is that they stop the complement from binding onto the RBCs because these are defective due to the mutation, stem cell mutation. These are not able to stop the complement from binding onto the RBCs. That is why they the complement binds easily to the RBC and then destroys it. That is the simplified version of this. But you need to remember all of this. This is just clear memorization. You would have to remember the GPI anchor synthesis is defected, the mutation is in PIGA, and the proteins that are affected are DAF, CD55, MERL, or CD59. Okay, there is a triad of Coombs negative, hemolytic anemia, pancytopenia, and venous thrombosis. This is a triad that is there. It's quite important. Coombs test will be negative because this is not autoimmune kind of a condition. This does not have any proteins associated with it. So this is a Coombs negative hemolytic anemia, right? This has pancytopenia, not just RBCs. It can affect the other cells as well because it is a stem cell mutation. So it can affect other cell lines as well, and venous thrombosis. So it can lead to Budd-Chiari syndrome. So you need to keep in mind the symptoms of Budd-Chiari syndrome. They can be given in a clinical scenario of paroxysmal nocturnal hemoglobinuria. Classically, the history is going to present with pink red urine in the morning, and again, it is associated with aplastic anemia and leukemias. So you keep this in mind that although we are studying this in the anemia section, this can lead to pancytopenia. So you need to keep this in mind. Okay, that's why I'm highlighting this point again and again. In labs, CD55 and 9 are going to be negative, of course, and RBCs on flow cytometry. Okay, so flow cytometry basically will check these proteins. So they're going to be negative on the flow cytometry. So if they ask you what test do we do, it is the flow cytometry. That is what you must answer. And what will we find on this test? You would find the absence of CD55 or 59. Treatment for this is eculizumab, which targets terminal complement proteins. This is the treatment. So keep this in mind. Eculizumab is used. Okay. G6PD deficiency, it's an X-linked recessive disorder. You must know this. And it's a defect in GCPD uh, enzyme. And it leads to decreased NADPH. And this increases RBC susceptibility to the oxidative stress. It is usually caused by oxidative stress is usually caused by sulfur drugs, antimalarials, and fabamines. So these things do not cause the G6PD deficiency. It's already present, but these things cause oxidative stress. The sulfur drugs, antimalarials, and fabamines, which, of course, if they cause oxidative stress, then the RBC cannot protect itself due to their decrease in NADPH, and this leads to hemolysis. And this can cause both extravascular and intravascular hemolysis. Okay, so you need to keep this in mind. Important. You will have back pain, hemoglobinuria a few days after the oxidant stress, and this is episodic. So this is episodic. Keep this in mind. It's going to be decreased G6PD activity on the labs, and you have to check the labs when there is not an acute hemolysis episode occurring. So you need to check the labs between episodes, because if you check it during the active hemolysis episode, then the activity can be normal because the cells are getting replaced fast. So new fresh cells are coming in and they can display normal G6PD activity. So that is why you have to do this between the episodes, not during acute hemolysis episodes. And blood smear will show RBCs with Heinz bodies and white cells. That's what the blood smear is going to show. And this is a mnemonic present here. Why does back pain occur in this defect is because oxidative stress or release of hemoglobin can cause myalgia, muscle spasm, and it can also cause a spasm. Hemoglobin present in the free vessels can cause a spasm of the vessel as well, constriction. And that vascular constriction can lead to the muscle receiving less blood, leading to cramps and back pain. So that is the basis of the back pain. Pyruvate kinase deficiency, it is autosomal recessive. So wherever there is mentioned, you have to remember what disorder it is. This was X-linked recessive. This was autosomal dominant. So wherever it is written, you have to memorize it. It is a pyruvate kinase defect, which means that glycolysis is affected, and there's going to be decreased ATP formation, which are going to lead to extravascular hemolysis. And decreased ATP formation is going to lead to rigid RBCs. So that's not important, but you must remember that this causes extravascular hemolysis. And for the to save this, to I might say an adaptation that the cell does to save itself from this fate is that it increases the levels of 2,3 BPG so that it can have a decreased hemoglobin affinity for oxygen. So if it has this decreased hemoglobin affinity for oxygen, then there's going to be what you may say that increased release of oxygen. So that's what the cell does. It increases the levels of 2,3 BPG. Hemolytic anemia in a newborn can be a sign of pyruvic kinase deficiency. So this is an important point. The blood smell will show the blood smear. Excuse me. The blood smear will show blood cells. So not really that much important from exam point of view, but still important to know what this is. Sickle cell anemia, arguably the most important in this. So again, a point mutation in the beta globin chain, and the mutation is where a single amino acid, glutamic acid, is substituted by valine, and it alters hydrophobic region on the beta globin chain, which means that the chains start to aggregate, and they start to aggregate and they give rise to a sickle cell shape. It is both extravascular and intravascular hemolysis. Why does the sickling occur? It has some stimulants such as low oxygen, high altitude, or acidosis. And you must remember these stimulants because these can be present in the clinical history of the question. And only deoxygenated hemoglobin polymerizes. So that is why these environmental triggers can lead to polymerization. Newborns are initially asymptomatic because there is increased fetal hemoglobin and decreased sickled hemoglobin. But as the age increases, fetal hemoglobin decreases. That is why newborns can get affected. That is why children can get affected with increasing age. Heterozygotes have resistance to malaria. Not very important point, but still nice to remember. Sickle cells are crescent shaped. You can see that they are crescent shaped, and crew cut appearance can be present on the skull X-ray due to marrow expansion from increased erythropoiesis. This can also be seen in thalassemias. So this can be seen in thalassemia and sickle cell uh, disorder as well, sickle cell anemia as well. These are the complications: aplastic crisis due to parvovirus B19, autosplenectomy, very important. What happens is that the sickled RBCs get deposited in the vessels of the spleen, which can lead to progressive atrophy of the spleen. And excuse me, right? So the RBCs get deposited on the splenic vessels, and that can lead to progressive atrophy of the spleen. And at some point, the spleen will get completely atrophied and it will stop working. So, autosplenectomy is a concept that occurs in sickle cell, and it can increase the risk of encapsulated organisms such as Salmonella osteomyelitis. So, this is important. You need to remember this. Again, splenic infarct sequestration can occur due to the sickled RBCs getting deposited in the vessels of the spleen, and there can be painful vaso-occlusive crisis. So again, it's the same concept that the RBCs get deposited into the small vessels of. If they get deposited into the small vessels of hands and feet, they can cause dactylitis. Dactylitis is basically the swelling of hands or feet because, of course, RBCs are deposited in the vessels. So that leads to the uh, hypoxic cramping and swelling of the tissue. Priapism can occur in which the RBCs get deposited into the penile vessels. Acute chest syndrome in which they get deposited in the pulmonary vessels. And acute chest syndrome is, you could say that acute chest syndrome is classified by respiratory distress, new pulmonary infiltrates, and on chest X-ray, and is a common cause of death. So acute chest syndrome is basically there is respiratory distress and there are new pulmonary infiltrates on the chest X-ray. Why it happens is because RBCs get deposited into the pulmonary vessels, and it can cause avascular and other complications can be avascular necrosis and stroke as well of sickle cell anemia. Sickling in the renal medulla occurs because renal medulla has decreased oxygen saturation, pressure of oxygen, and what happens is that it leads to the sickling in the renal vessels, and it causes renal papillary necrosis, which can lead to hematuria. Now, something important about this is that this is also present in the sickle cell trait. So, all of the above mentioned complications are not going to be present in the sickle cell trait, they're going to be present in sickle cell disease. But this is going to be present in the sickle cell trait as well. So, if they ask you what one thing is present in sickle cell trait, hematuria is present in the sickle cell trait. More of these complications can occur in sickle cell disease, in the full sickle cell disease. You can carry out electrophoresis. It is going to show decreased hemoglobin A, increased hemoglobin F, increased hemoglobin S, and the treatment is going to be hydroxyurea, which increases fetal hemoglobin and hydration. You need to keep in mind the electrophoresis part, which can show you, they can ask you this in your exam. HBC disease is a glutamic acid to lysine mutation occurs in the beta globin chain, and it causes extravascular hemolysis. Uh, HBSC, one of each mutant gene milder than HBSS. Blood smear in homozygotes, hemoglobin crystals inside, and they target the RBCs. So, not really important disease, but you just have to know the mutation. The glutamic acid to lysine. Over here, it was glutamic acid to valine, and this is glutamic acid to lysine. Not that important. You can let go of it. Extrinsic hemolytic anemias now, starting off with autoimmune hemolytic anemia. It's a normocytic anemia that is usually idiopathic and Coombs positive. So last time we studied that paroxysmal nocturnal hemoglobinuria is, although it has a sort of a related mechanism with hemolysis, it is a Coombs negative anemia. This anemia is a Coombs positive anemia, and it is of two types. Primarily, it is of a warm type, which is chronic, and let me highlight it. So it is chronic, and primarily it involves IgG and extravascular hemolysis. And the important part about this is that it is seen in SLE and CLL also, along with certain drugs that can cause this, such as beta lactams, alpha methyl dopa, So this is the most important part. Whereas the cold one is acute, right? It involves IgM and complement and causes the agglutination and extravascular hemolysis of RBCs upon exposure to the cold. So it is also painful. It is also painful. It can cause painful blue fingers and toes, and it is seen in CLL. Mycoplasma pneumonia infection and infectious mononucleosis. So you need to know the difference between both of them. These are very important. Uh, Worm is chronic, involves IgG, seen in SLE and CLL with certain drugs. So drugs are in worm, right? Beta lactams, methyl dopa, and SLE is also in worm. IgG is in worm, and chronic anemia is in worm. Cold is acute, and it also involves IgM and complement, which is different, and it causes painful blue fingers and toes. And it can be a complication of mycoplasma pneumonia infection or infectious mononucleosis. So something which you need to keep in mind. Spherocytosis can be seen. We've discussed this, that there are two disorders in which spherocytosis can be seen. One of them is hereditary spherocytosis, and the other is autoimmune hemolytic anemia. And agglutinated RBCs can be seen on peripheral blood smear. The treatment for warm autoimmune hemolytic anemia is steroids and rituximab, or you can go for splenectomy if it is refractory. For the cold one, you have to do cold avoidance. This is the most important part, and rituximab can also be used in this. Rituximab can also be used in the cold autoimmune hemolytic anemia. Drug-induced hemolytic anemia is most commonly due to antibody-mediated immune destruction of RBCs or oxidative injury via free radical damage, which occurs in G6PD deficiency. So, you know the mechanism of both of them. You discussed both of them. Common causes include antibiotics. Sometimes penicillins and cephalosporins can cause drug-induced hemolytic anemia, NSAIDs, immunotherapy, and chemotherapy. Spherocytes suggest immune hemolysis, so spherocytes will be present. And spherocytes, wherever they are present, they always suggest immune hemolysis. Bite cells suggest oxidative hemolysis and can cause both extravascular and intravascular hemolysis. So, something that you need to keep in mind. They can also have bite cells. So, just keep in mind the drugs that can cause it: penicillins and cephalosporins, NSAIDs, immunotherapy, chemotherapy. Microangiopathic hemolytic anemia, RBCs are damaged when passing through obstructed or narrowed vessels, causes intravascular hemolysis. And the causes are important, which is DIC, TTP, HUS, SLE, HELP syndrome, and hypertensive emergency. Students usually forget SLE and HELP syndrome. It's very important that you remember them. And also DIC. Students usually forget all three of them. So it's important that you keep these in mind. And schistocytes are going to be seen, which are also known as helmet cells. And schisto means to split. Macroangiopathic hemolytic anemia, on the other hand, is seen with two classical causes, such as prostatic heart valves and the aortic stenosis. You need to remember both of them, and they cause hemolytic anemia secondary to mechanical destruction. So, these are the two most common causes of macropathic hemolytic anemia: prostatic heart valves and aortic stenosis. And schistocytes can be present here as well. I just like to think that because it has the word macro in it, then because valves are bigger than vessels, so valves cause macroangiopathy because valves are bigger than vessels, and both of them involve valves. So aortic stenosis also involve the valves, and the prostatic heart valves also involves the valves. So it's bigger than the vessel. That's how I remember it. And hemolytic anemia can be due to infection as well, in malaria and babesia. Leukopenia is neutropenia is when absolute neutrophil count is less than 1500 cells per millimeter, and severe infections occur when the count is less than 500. Lymphopenia is when absolute lymphocyte count is less than 1500 cells and less than 3000 in children. I think if you want to remember one of them, I think you should remember lymphopenia. It's more important. Eosinopenia is when the absolute eosinophil count is less than 30. Neutropenia causes are sepsis or post-infection. Drugs, including chemotherapy, of course. Aplastic anemia can cause this. SLE can cause it. Radiation, um, congenital infection can cause it. Cottage syndrome can cause this, and congenital HIV. So this is continuing here. The sentence is continuing here. Glucocorticoids, radiation, sepsis, post-operative. Eosinopenia, I would say to remember the cause of eosinopenia. The cause of eosinopenia, which is Cushing syndrome and glucocorticoids. This is very important. Both of them, they cause eosinopenia, right? So this is important. Glucocorticoids can cause neutrophilia despite causing eosinopenia and lymphopenia. So you need to remember this. Yes. So they cause neutrophilia, but they cause eosinopenia and lymphopenia. So they increase the neutrophil count but decrease eosinophil and lymphocyte count. Glucocorticoids can decrease activation of neutrophil addition molecules, which can lead them to detach from the vasculature and migrate into the sites of the inflammation or the sites of the infection. So in blood, the apparent neutrophil count will increase. However, most neutrophils are present attached to the vessel. So if this is the vessel, most neutrophils are like this, right? So if you start taking glucocorticoids, they are going to detach and they are going to float freely in the blood. So the apparent count will be increased. It's not that glucocorticoids add more neutrophils to the body. They are just detaching the ones that are already present, right? So in contrast, glucocorticoids sequester eosinophils and lymph nodes and cause apoptosis of lymphocytes. So the reason why they increase neutrophil count I've already explained. But why do they explain? Why do they decrease the eosinophil count? Is because they sequester the eosinophils and they cause apoptosis of lymphocytes. So that's the reason why the eosinophil and lymphocyte count decreases in glucocorticoid use, but neutrophil count increases. So it's the point that is important. You must keep it in mind. Okay. So heme synthesis, porphyrias, and lead poisoning now. Right. So the porphyrias are hereditary or acquired conditions of defective heme synthesis that lead to the accumulation of the heme precursors. Lead inhibits specific enzymes, leading to similar conditions. And now they've described the all the porphyrias in different part. So every condition affecting the heme synthesis is basically described. So lead poisoning, we've already studied. It blocks the furochelatase and the ALA dehydratase enzyme. Accumulated substrates are protoporphyrin and ALA. I've already explained this disorder in the previous lectures. Presenting symptoms are microcytic anemia, basophilic stippling, very important, uh, and ringed sideroblast in the bone marrow. So basophilic stippling in the peripheral smear and the ringed sideroblast in the bone marrow, and can also cause GI and kidney disease. Children get affected due to exposure to lead paint. It causes mental deterioration in them. And adults get environmental exposure from batteries, ammunition. So basically, occupational exposure if they work around these things. And what can be the manifestation of this in adults? It can be headache, memory loss, demyelination. Demyelination is mentioned here, but the primary problem is peripheral neuropathy, which is important for you to keep in mind. Okay, so acute intermittent porphyria. These are the main porphyria. So this this disorder affects this enzyme. So porphyrobilinogen deaminase. This is an autosomal dominant mutation. Porphyrobilinogen deaminase is affected. So this enzyme right over here is affected. So porphyrobilinogen is going to accumulate, obviously, and the subsequent pathway is going to decrease. All right. So what happens? Porphyrobilinogen increase accumulates and ALA accumulates. So ALA is the precursor. So it will always accumulate whenever there is going to be any problem in the heme synthesis pathway. The symptoms are described by the five P's. So painful abdomen, port wine, colored urine, polyneuropathy, psychological disturbances precipitated by factors that increase ALA synthase. So if ALA synthase is going to increase, there's going to be increased formation of porphobilinogen, which of course will lead to the toxicity in itself. So such drugs are CYP 450 inducers. These are very important for your exam: alcohol or starvation. So you have to keep this in mind. These are important. So CIP 450 inducers are important for you guys to remember. And the treatment is also very important, which is hemin and glucose. So why is this the treatment? Is because if you give hemin and glucose to the patient, which is this part, this part, right? So if you give hemin and glucose to the patient, it's going to refill this, these precursors. So what's going to happen is that this precursor is going to this is going to accumulate, and the process is not going to continue onwards. So this substrate is going to decrease. This is the main culprit causing problems. Porphyria cutanea tarda. The problem here is uroporphyrinogen decarboxylase. So uroporphyrinogen 3 is going to accumulate, and it is going to uh, give tea colored urine. So it was port wine colored over here. This is tea colored over here. You need to remember this because it is cutanea tarda. So you can remember tea from tarda in the first initial of the tarda spelling. Now, because this has the word cutaneous, so we know that this has some skin manifestations. Specifically, it can cause blistering, cutaneous photosensitivity, and hyperpigmentation. So, if they're talking about a porphyria and it has a skin manifestation, you know they're talking about PCT or porphyria cutanea tarda. This is the most common porphyria as well. So keep this in mind. This is the most common porphyria. This is exacerbated by alcohol consumption, like this as well. This is exacerbated by alcohol consumption as well. So alcohol is bad for people with porphyria. The causes are familial or hepatitis C. So hepatitis C is an important cause of PCT. It's quite important. Treatment is phlebotomy, sun avoidance, and anti-malarials. So remembering anti-malarials is quite important. Phlebotomy is also important. Phlebotomy removes the porphyrinogen from the blood. The reason is that this gets accumulated in the blood, right? So this gets accumulated in the blood, and whenever the patient is exposed to the sun, because this is present in the blood, it gives rise to manifestations in the skin. So if we carry out phlebotomy, we are basically removing this from the blood. We are basically removing the substrate from the blood, right? That is why phlebotomy works. Sun avoidance, it's quite clear. If you avoid the sun, photosensitivity will not occur, and hydroxychloroquine is for some reason important in this disease. So that's it for porphyrias. You can check out this diagram. It's going to help you clear a bit of your concept.